hysterectomy, a woman who had salpingitis. Again, we can see the cervix here. There's the fundus of the uterus. You can see the fallopian tube here on this side. There's the ovary. There's the fimbria right here. Now, if you take a look at this part of the uterus, this is the normal color of the uterus. It's got that kind of orange tan color to it. Take a look at this fallopian tube. You can see it's kind of a red color. It's very erythematous. This is what a salpingitis would look like. And it's clearly inflamed. The fallopian tube is clearly inflamed, very red in color. But that's not the worst case of salpingitis. Take a look at this side of the uterus. Look at this fallopian tube. You can see it's massively distended here on the right side. This fallopian tube not only is inflamed, but it's abscessed. And this is something we very commonly see in pelvic inflammatory disease caused by things like gonorrhea. Gonorrhea is a very pyogenic infection. As a result, when it infects the fallopian tubes, it very often causes an abscess to form. Now, it's very difficult to treat an abscessed fallopian tube. We've talked about this a number of different times. Simply treating this with antibiotic probably will not be successful. It's very difficult to get the antibiotic into the abscess. Even if it does get into the abscess provides a very acidic environment in which the antibiotic can denature. And so it's very difficult to treat an abscessed fallopian tube like this. And very often, the only alternative we have is a salpingectomy. Sometimes we have to remove the fallopian tube. Sometimes that salpingectomy will be unilateral, sometimes it'll be bilateral. Sometimes we just resort to removing the entire uterus. It's very difficult to treat a salpingitis, which is remarkable for these abscesses. And so we have to resort to things like removing the fallopian tube. Now, even if we were to successfully treat this abscessed fallopian tube, chances are the fallopian tube is going to be badly scarred down. It's going to be useless anyway. In fact, it'll probably be a liability. If the fallopian tube is scarred down, again, there is a risk that a zygote will get caught somewhere in the lumen of the fallopian tube and implant, resulting in an ectopic pregnancy. Any questions on that? Okay, ectopic pregnancies are usually fatal if they're not treated. Eventually, what will happen is as the fetus develops in the fallopian tube will rupture and the woman will hemorrhage to death. And so ectopic pregnancy is something of an emergency. If we discover an ectopic pregnancy, usually we have to intervene right away to either stop the hemorrhaging or prevent the hemorrhaging altogether. Any questions on this? Okay, let's talk about some of the pathology associated with the ovaries. Let's first begin by talking about cysts. Ovarian cysts, very common condition. There are generally two types of cysts. There are follicular cysts and there are luteal cysts. Difference between the two. A fallopian cyst, or excuse me, a follicular cyst is usually a cyst that develops from a follicle that develops but never ovulates. So as the follicle develops, never ruptures, generally what happens is over time it just kind of degenerates into this follicular cyst that persists on the surface of the ovary. A luteal cyst is an example of a follicle that ruptured but then resealed, and as a result persists as a cystic structure on the ovary. Whatever be the case, these follicular and luteal cysts eventually contain fluid which is very irritating to the peritoneal cavity. The biggest problem with these cysts is that sometimes they will leak this fluid, usually about mid-cycle, around the time of ovulation. They tend to leak this very irritating fluid into the peritoneal cavity, causing a peritonitis. That causes the woman a lot of pain about mid-cycle. This spectrum of symptoms occurring as a result of leaking of the fluid around mid-cycle is called Mittelschmerz syndrome. Mittelschmerz syndrome. It can be a source of great pain to a woman, again, around mid-cycle when these cysts tend to leak. Let's take a look at an example of one of these cysts. Here's an example of a follicular cyst. Again, this is a cyst caused by a follicle which develops but never ruptures, never ovulates, and eventually involutes, forming this persistent structure we call a cyst filled with very irritating fluid. This is a section through the ovary. You can see the cortical region of the ovary here. You can see the medullary portion of the ovary here. The ovary is very vascular in the medulla. Okay. Over here in the cortical region, you can see this very smooth-walled cyst. This is an example of a follicular cyst. It's a benign cyst. Again, it just is a remnant of a follicle that never ovulated and as a result degenerated into this structure containing this very irritating fluid. Again, the biggest problem with these cysts is that they tend to leak this very irritating fluid around mid-cycle, causing Middleschmerz syndrome. Usually, if the cysts are not removed surgically or the ovaries not removed, eventually what happens is that these cysts will involute. It takes months, but generally the cysts will involute on their own. But again, there's this issue around mid-cycle where it can cause a lot of discomfort to the woman. Any questions on this? Okay, let's take a look at polycystic ovarian syndrome. And this goes by many names. The latest name is polycystic ovarian syndrome, or POS for short. In the past, it's been called polycystic ovarian disease. And before that, it was called Stein-Leventhal syndrome. And it's not necessarily clear which name your authors will use on the boards. They will most likely refer to it as polycystic ovarian syndrome, but they could use one of the older names for it. A couple of important things to know about this condition. Firstly, you need to know it's an anovulatory state. It is a disease in which the woman is anovulatory. And so as a result, women with POS will typically present with infertility. It is a condition that usually affects perimenarcheal women and perimenopausal women. Women right around the beginning of their fertile cycle, fertile life, and women right at the end of their fertile life. Now, this condition represents a couple of different problems. First of all, the woman is infertile. The condition is usually characterized by multiple cysts accumulating on the ovary, and these cysts can cause trouble in and of themselves, and that's why we call it polycystic ovarian syndrome. Now, it seems that when a woman becomes anovulatory as a result of this disease, a lot of follicles in the ovary develop, but none of them ever actually rupture, none of them actually ovulate. And again, they kind of degenerate, persisting as these follicular cysts. And over each cycle, more and more of these follicular cysts will accumulate. And then finally, in the end, the ovary is remarkable for multiple cysts. Each one of these cysts can have some fluid in them that can cause a lot of pain if it starts leaking out to the peritoneal cavity. And as a result, there can be some mid-cycle discomfort caused by this condition. Now, there does seem to be a genetic component to developing this disease. It seems to be related to an autosomal dominant inheritance pattern. There are some other factors, of course, involved, but it does seem to be an autosomal dominant condition. The autosomal dominant condition does have variable penetrance, meaning that you could have the mutant allele that causes the disease, but because of variable penetrance, one may or may not develop the disease. Again, it depends on other factors as well. Now, there are a number of different criteria which we use to diagnose this condition, but there are some important hormonal relationships that you should understand which will help you identify this condition. And you have to understand these hormonal profiles. So let's take a look. The hormonal profiles are listed on page 25. You should understand with polycystic ovarian syndrome, number one, a woman has high levels of androgens. Number two, she has high levels of estrogens. She has low levels of progesterone. low levels of FSH and high levels of LH. You should know those 5 hormonal relationships. All of those hormonal irregularities are associated with polycystic ovarian syndrome. Now, to understand the relationship of all those different hormonal levels, we have to understand something that governs the pituitary ovarian axis. We have to understand some of the negative feedback loops that govern the pituitary ovarian axis. So let's take a look at that. Again, I said a couple of things. Number one, androgen levels are high in a woman with polycystic ovarian syndrome. Number two, estrogen levels are high. Let's take a look at why that is. We can understand some of the hormonal relationships by examining the pituitary ovarian feedback loops that govern the production of estrogen in the ovary. Let's take a look at that. Here is a graphical depiction of that negative feedback loop. Estrogen secretion by the ovary. Control begins in the pituitary axis. The pituitary gland elaborates follicle-stimulating hormone from the gonadotropes located in the pituitary gland. The gonadotropes located in the pituitary gland elaborate FSH. This FSH will stimulate some of the follicles in the ovary to begin developing. These follicles that develop will start elaborating estrogen. The high levels of estrogen will then feedback and inhibit on the gonadotropes located in the pituitary gland, completing a negative feedback loop. And I said there were a couple of hormonal relationships we needed to understand. One of them was high levels of estrogen and low levels of FSH. Well, that's related to this negative feedback loop. If you have abnormally high levels of estrogen, the high levels of estrogen will feedback and inhibit on the gonadotropes in the pituitary gland, and that reduces the production of FSH. As a result, in polycystic ovarian syndrome, we have high levels of estrogen, low levels of FSH. That's a direct consequence of this pituitary ovarian negative feedback loop. The other thing I said is that we have very low levels of progesterone and very high levels of LH. Let's take a look at that. Well, the relationship between LH and progesterone shown in this negative feedback loop. Again, within the pituitary gland, we have these gonadotropes producing luteinizing hormone. Luteinizing hormone operates on a ruptured follicle, converting it to a corpus luteum. The corpus luteum then produces progesterone under the influence of LH. Progesterone levels rise, and that will feedback inhibit on the gonadotropes located in the pituitary gland, reducing the production of LH, again completing a negative feedback loop. I mentioned that one of the other irregular hormone levels includes very low levels of progesterone and very high levels of LH. I also said that PCOS was characterized by an anovulatory state. Well, if you don't have ovulation, you can't form a corpus luteum. If you can't form a corpus luteum, you can't produce progesterone. No progesterone, you disinhibit the gonadotropes that are producing LH in the pituitary gland. And as a result, there's very little progesterone and very high levels of LH. And that's one of the other hormonal abnormalities you see in this condition. Very low levels of progesterone, very high levels of LH. Okay. Now, we emphasized a few times that this condition is characterized by an anovulatory state. It seems that the hormonal irregularities create a self-perpetuating anovulatory condition. And to understand why, we have to understand something about what triggers ovulation in the ovary. Here's a representation of some of the different hormonal fluctuations throughout a woman's cycle. Down here, we have a representation of some of the changes that occur in the uterus as a function of woman's cycle. And over here, we have some of the changes that occur in the ovaries as a function of woman's cycle. Now, we've gone through the various changes in the ovary and the uterus throughout the woman's cycle. Generally, in order to trigger ovulation, one needs to have a spike in FSH and LH mid-cycle. This dynamic change in FSH and LH is ultimately what triggers ovulation in a follicle. And then the follicle subsequently will change into a corpus luteum. You recall that in PCOS, FSH levels are constantly depressed and LH levels are constantly high. And as a result, during mid-cycle, you have no mid-cycle spike in these hormones, FSH and LH. There's no dynamic change in the levels of FSH and LH. And as a result, no spike, no ovulation. And so this condition is actually self-perpetuating. As long as the FSH levels are low and the LH levels are high and there's no dynamic change in these hormones, there is no surge in these FSH and LH, these gonadotropins, that will trigger ovulation. And as a result, the condition is self-perpetuating. Once it starts, it's self-perpetuating. The woman cannot ovulate. Now, I also said this condition was characterized by multiple cysts in the ovary. That's usually one of the findings. It doesn't have to be, but usually PCOS, polycystic ovarian disease, is characterized by multiple cysts found in the ovary. Let's take a look at that. Let's first take a look at a normal ovary. Here's a normal ovary. This happens to be a simian ovary. You can see a lot of the normal anatomy of the ovary here. As we have the cortical region of the ovary, there's the medullary region of the ovary. If you take a look at the cortical region of the ovary, you can see lots of developing follicles. See, these are all normal follicles here, right here in the cortical region. You can tell they're normal follicles because if you look inside the follicle, you'll see that. What's that? What do you think that is? That big cell right in the middle of the follicle. Right off to the side. That's oocyte. That's the egg. Right there. And it's right there in the follicle. Those are normal follicles. You can tell they're normal follicles because each of them contain an egg. Okay, all these are normal follicles. Everything is fine in this ovary. Now, eventually, one or more follicles is going to rupture, and the ovary, of course, will ovulate, produce an egg. They'll be picked up by the fallopian tube, and everything will be fine. In polycystic ovarian syndrome, none of these follicles will rupture. None of them will ovulate, and as a result, these follicles will degenerate into what we call follicular cysts. Let's take a look at that. Here's an example of a section through an ovary, remarkable for follicular cysts. Again, you can see we got a section through the ovary here. There's the medulla. There is the cortical region of the ovary. And if you take a look in the cortical region overlay, you see these. Okay, these kind of look like follicles, like we saw before, except they're not follicles. They're cysts. How do I know they're cysts? Take a look inside the cyst. Do you see any egg? You don't see any egg at all. That's because the follicle is degenerated into a simple cystic structure. There is no egg, and these are simply persistent degenerative remnants of the follicles. These no longer contain oocytes. They are no longer considered follicles. They are just follicular cysts. And these cysts will accumulate every cycle because the woman is not ovulating. If the follicles don't ovulate, they will degenerate into these remnants we call follicular cysts, hence the name polycystic ovarian syndrome. Again, an anovulatory state. Okay, let's talk about some of the important presenting features. Remember, you have to know those hormonal relationships we discussed. High androgens, high estrogens, low progesterone, low FSH, high LH. You got to know those 5 hormonal relationships that you see in polycystic ovarian syndrome. Okay. The presentation, typically a woman with PCOS is going to be anovulatory. She won't be ovulating at all. She probably will be hirsute, meaning she will have facial hair. That facial hair is caused by the high levels of androgen, and those high levels of androgen result in what we call hirsutism, certain hair development consistent with male secondary characteristics. That's due to the high levels of androgen. She'll be infertile, and typically a woman with PCOS tends to be heavyset. Doesn't have to be the case, but she tends to be heavyset. So typically a woman with PCOS will be heavyset and hirsute. She'll be kind of on the heavy side with facial hair. All right, the workup. Again, you will find these hormonal abnormalities when you work a woman up. The ovaries will be enlarged. They're most likely will be studded with lots of cysts. However, that is not a requirement to make the diagnosis. About 30% of women actually don't have these abnormal cysts in the ovary. And so the presence of multiple cysts is not a diagnostic requirement. Okay. Usually the cortical region of the ovary will be thickened, and you'll see a conspicuous absence of corpora lutea. There'll be no corpus luteum. Why? Because the woman's not ovulating. You need ovulation to produce a corpus luteum. Okay. Now, we do have diagnostic criteria to properly make the diagnosis of PCOS. The diagnostic criteria is called the Rotterdam criteria, and you must have two of the following three things in order to make the diagnosis of polycystic ovarian syndrome: oligo-ovulation or anovulation, excessive androgen production, polycystic ovaries diagnosed by ultrasound. Again, any two of those three criteria will get you the diagnosis of PCOS.
What's the third one?
Polycystic ovaries by ultrasound. So, anovulation, excessive androgen production, or polycystic ovaries. Those are the Rotterdam criteria. Okay, any questions about PCOS? Okay, let's take a look at some more pathologies of the ovary. First, we'll take a look at some of the different tumors of the ovary. Okay, before we examine the different types of tumors that develop in the ovary, we have to understand the cellular composition of the ovary. There are three main types of cells that you find in the ovary. Each type of cell can give rise to a different group of neoplasms. Now, the ovary has a number of different cells that can be classified as totipotent and multipotent cells. Totipotent cells means that the cell can differentiate to any type of cell in the body. It has no restrictions. It can differentiate any type of cell produced in the body. Multipotent cells simply means that the cells can differentiate to a certain subset of different types of cells in the body. You can't differentiate all types of cells, but just a subset of cells. Okay, let's take a look at each one of these. Let's first talk a little bit about the different types of cells and their potential. Okay, here we have a little depiction of the ovary. Again, you can see some of the different components. You can see the medullary area here. There's a cortical region. Okay, we've got the different types of cells that you find in these different regions. Let's first talk about the surface epithelial cell. Okay, this is the mesothelium of the ovary. It's just the outer cell layer that coats the ovary. These cells are multipotent, meaning that they can differentiate to a subset of different types of cells. As a result of their multipotent cell type, they can give rise to a variety of different types of neoplasms. Most of the different malignant neoplasms of the ovary actually develop from the surface epithelial cells. These surface epithelial cells can give rise to some pretty nasty types of tumors, malignant neoplasms. Serous adenoma is a good example. Mucinous adenoma is another example. Okay, there are several more examples. But 90% of all the malignancies of the ovary develop in this one cell layer type, the surface epithelial cells. And they're multipotent, meaning they can differentiate along a subset of cell lines. Then we have the germ cells. Germ cells are the eosinophils. Okay. Now, a whole human being has to develop from one of those cells, and so they are totipotent. They can develop into any of the cells found in the body, and they give rise to some pretty strange types of tumors. They don't account for many malignant neoplasms, maybe up to 5% of the malignant neoplasms, but when they do produce neoplasms, they are very strange neoplasms, including the teratoma. We talked about the teratoma. Teratoma is usually a cystic type of tumor. consists of a variety of different cell types: hair, teeth, bone, neural tissue, muscle tissue. There's all kinds of tissues that you find in a cystic teratoma. And that's because they arise from a totipotent cell, a germ cell. You can differentiate into any. Dysgerminoma is another interesting one. That dysgerminoma is analogous to the male seminoma. You're going to have to know that for your boards. Sometimes your board authors ask you that. The dysgerminoma is analogous to the seminoma in the male. Okay. I'm not quite sure why they ask that, but it's a question that's come up multiple times on the boards. All right, so those are the germ cells. Again, they differentiate along any kind of cell line. The most interesting types of tumors, the teratomas and the dysgerminomas. Then we have the sex-gored stromal cells. Now, most of the time, when these cells lose proliferative control, they give rise to benign neoplasms. Not malignant neoplasms, but benign neoplasms. Of course, they can give rise to malignant neoplasms also, but usually they give rise to benign neoplasms, including things like fibromas, and these are benign. Granulosa thecal cell tumors, Sertoli-Leydig cell tumors. And the biggest problem with these benign neoplasms, like the granulosa thecal cell tumor, is they sometimes produce excess androgens or excess estrogens, and they can cause endocrinopathies, and that's sometimes how they present. They present with a number of different symptoms associated with excessive production of sex hormones like androgens and estrogens. Okay, any questions on these different cell types and the tumors they give rise to? Okay, let's take a look at one of these tumors. You may have seen this in one of our lab questions. This is an example of a teratoma. These teratomas usually grow in cystic form. Again, they arise from the germ cells. Germ cells are totipotent. They have to give rise to every single cell in your body. And so when they go ballistic, they differentiate along all kinds of different cell lines, giving rise to hairballs, teeth, cartilage, some fat there, and I don't know what else is in there. But there's all kinds of different tissues. Usually the radiology of these cystic teratomas are remarkable for all kinds of different radiodensities due to different tissues.
Is there a certain area in the body where teratomas will go?
There are generally two places where teratomas develop: the ovary and in the periorbital region. The periorbital region, usually teratomas will develop in neonates for young individuals. Those teratomas are typically benign, but they do have all kinds of tissues in them. Okay. I can probably give you a look at one of those teratomas that develops in the periorbital region. Where that is. Here's an example of how a teratoma in a toddler might present. Again, you've got a tumor here developing the periorbital region. Okay, now very commonly, this is due to some ectopic rest of totipotent cells, and it tends to develop in this area as a result. Again, usually these teratomas are benign. These types of teratomas that develop in the periorbital region are often called dermoid cysts. This is, again, what it looks like. Again, it's a cystic tumor. You can see the outer enclosing layer, and look what you got inside here. It's the big tooth. These are very interesting tumors.
Do you have a picture of an X-ray of that?
Radiograph
Yeah.
of teratoma. Let's see if we can find it. Some of them are benign, some of them are malignant. The benign teratomas are sometimes called mature teratomas, whereas the malignant teratomas are called immature teratomas. The mature teratomas you can scoop out. You can actually use blunt dissection, scoop it out with your fingers. It's not very adherent to anything, whereas the malignant neoplasms usually stick to everything. You have to cut those out. Comes up. And there's an example.
So those are teeth?
Those are bones and teeth.
So weird.
Yeah. A lot of different radiographic densities applied in there. All right, any questions on that? All right, just a few other things. Pathogenesis for these ovarian tumors. The biggest problems seem to be related to mutations in the p53 gene. Recall the p53 gene is a major cancer suppressor. So it seems that a lot of these ovarian tumors are remarkable from some sort of deactivating mutation in the p53 gene. It's also known that pregnancy and oral contraceptive use kind of lowers the risks for these different types of tumors. That makes sense when you think about the cycling of a woman. When she's pregnant, she doesn't cycle. She's on oral contraceptives. She doesn't fully cycle. If you stop the cycling, then you stop the cycling of the growth and atrophy of these different cells, and cells don't have to replicate their DNA all the time. They don't mutate, and as a result, there's a decrease in the incidence of these tumors that develop as a result of those mutations. Okay, anything on ovary? All right, let's take a look at breast now. I'm going to breast pathology. And we'll take the next few minutes just to examine normal histology of the breast. Okay, let's begin with a section through a relatively young breast, like a breast in a woman during her fertile years. This is an H&E stained section. You can see there are three primary tissue components that you find in the breast. You find, of course, lots of glands here. These are milk-producing glands you see in here. You also see some fibrous tissue, and you see some adipose tissue here. So these three major components typically found in the breast: glandular tissue, fibrous tissue, and adipose tissue. Now, the proportion of these tissues will change as a function of a woman's age. Usually, when a woman is younger than the age of 35, the breast will contain a relatively high proportion of glandular tissue and fibrous tissue. However, when a woman passes through the age of 35 to 40, the proportions of these tissues will change. The amount of glandular tissue decreases and the amount of adipose tissue increases. And so this change in histology is responsible for a number of different phenomena that we observe clinically. Young breast tends to be firm and formed, whereas older breasts tend to be less firm and less formed. That's because an older breast is remarkable for a higher proportion of adipose tissue rather than firm glandular tissue. Let's take a look at all of this. Let's take a look at a postmenopausal breast. Okay, we got a section through the thoracic cavity. We're over on the right side of the thoracic thorax. Again, you can see over here, you can see the right lung. You got the upper, middle, and lower lobe over here. There's the diaphragm. Just underneath, you can see the liver right over here. And of course, over here, you can see the breast. There's the nipple. If you look at this tissue, you can see most of this tissue is yellow. That's adipose tissue. When a woman increases in age, especially beyond the age of 40, a greater proportion of the breast tissue will be composed of adipose tissue. You can still see some glandular tissue here. Maybe these areas are kind of red. It might be glandular tissue. You also see some white tissue. That's the fibrous tissue. So you can see glandular tissue, adipose tissue, and fibrous tissue. In this postmenopausal breast, however, you can see that most of the breast is composed of adipose tissue. That's an important clinical phenomenon, this histologic change. It is an important determinant of how we can image the breast and when we can image the breast. Very often we image the breast, we're looking for some sort of cancer that has an aqueous radiodensity. In a younger breast, it is very difficult to identify a cancer radiodensity, which is an aqueous radiodensity, a whole background of fibrous tissue and glandular tissue, which also has an aqueous radiodensity. There's no contrast between the cancer and the rest of the breast. However, when the woman passes through the age of 40, a lot of the breast is now adipose tissue, which is very radiolucent. And so if you image the breast after the age of 40, you can look for a cancer which has an aqueous radiodensity and background of adipose tissue, which is very radiolucent. As a result, you have very high contrast between the cancer and the rest of the breast. As a result of those radiographic properties, generally we only get mammograms, radiographs of the breast, mammograms in women over the age of 40. If we try to get a mammogram in a woman less than the age of 40, it's usually very low yield, low sensitive. You're looking for a radiodensity of cancer that is no different from the radiodensity of the breast. There's no contrast. You can't really see it. Let's take a look at all that. Let's take a look at the different radiodensities of young breast versus an older breast. Here's an example of a younger breast. These are two images of the right and left breast put together so that we can compare symmetry to both breasts. There's one breast, there's the left breast, that's the right breast. You look at the image of the breast, you can see it is remarkable for lots of radiodensity equal to generally water, aqueous radiodensity, very dense radiodense breast. However, as the woman passes from 35 to 40, a lot of this dense radiographic tissue, like fibrous tissue and glandular tissue, is replaced with adipose tissue. And as a result, the radiodensity of the breast decreases, becomes more radiolucent. Here's an example of a mammogram of a woman who's 40 years of age. And you can see it's much more lucid. There's much more lucid background because it's more, composed of a greater proportion of fat. In fact, you can see a lot of the different blood vessels and Cooper's ligaments within the breast. You can also see some of the lactiferous ducts converging on the nipple here. Very easy to identify a cancer growing in a lucent background like this. It is nearly impossible to identify a cancer in a very radiodense background like that. Okay. Let's take a look at a time-lapse mammogram. Okay, these are two mammograms of the same woman. Here she is at age 35. Again, you can see the image of the breast right here. The nipple's about here. You can see at age 35, she still has some glandular tissue, fibrous tissue, and the breast is starting to become a little more radiolucent because it's being infiltrated with fat. Here she is 5 years later. Nipple here, again, you can see there's a remarkable decrease in the radiodensity of the breast. by age 40. And again, that's because by the time she passes from 35 to 40, a considerable amount of glandular tissue and fibrous tissue has been replaced with adipose tissue. Again, if you're looking for a cancer which would have a radiodensity like that in a breast like this, it's going to be easy to miss. However, if you're looking for a radiodensity like that of a cancer here somewhere in this background of adipose lucency, it's very easy to identify. You can see a very radiodense spot right there where the cancer is growing. Any questions on that? Yes.
Will the declining glandular tissue take place even if the woman becomes pregnant?
That's a good question. The radiodensity of breast will depend on hormones. If she's pregnant, or if she's pregnant, which is a hyperestrogenic state, then the glandular tissue of the breast is going to be maintained, and she will continue to have a high radiodensity throughout her pregnancy and even after the pregnancy. Also, the glandular tissue of the breast will be sustained if she's taking estrogen supplements. It's only after the estrogen levels go down that the breast will involute and become infiltrated with a lot of adipose tissue. Anything else? Okay, let's go ahead and take a break here.